Today we shall discuss benign breast disease and mastalgia, which will be a case-based discussion. I am Dr. Sabha. I am an endocrine and breast surgeon. And coming to introduction, benign breast disease includes all non-malignant conditions. This does not mean increased risk of malignancy. There is no increased risk of malignancy. These are a group of disorders which is misdiagnosed and misunderstood. It needs an interdisciplinary collaborative model of care. Coming to the anatomy of the breast, here you can see it has a fascia, it has a fibrous tissue, it has adipose tissue and glandular tissue. And coming to the basic unit, which is a lobule, here you can see the lobule. Then there is a main duct which empties into the sinus, then through the ampulla in the nipple. And coming to the most important physiology, the most important thing to understand is for the duct growth estrogen is needed, and estrogen and progesterone are needed for lobular alveolar growth, and prolactin for milk secretion. This is the most important thing. And coming to the first patient, she was a 25-year-old female lady with cyclical mastalgia since 1 year. She had a mild throbbing pain, no history of nipple discharge, no previous history of any surgery. She did not have history of diabetes or hypertension. She had normal menstrual cycles. She was married with no children. And similar disease was seen in both her mother and grandmother. So she went to a local doctor who prescribed these antibiotics, and with this the pain did not subside. So she went to some other doctor who prescribed some other antibiotics. Here you can see this is the patient, this is her mother, grandmother, husband and her father. So for a small benign problem of cyclical mastalgia, so many people have come to show the patient. So this, for a surgeon or for a mastologist, it might be a small problem, but for the patient it's a real issue. So you should not ignore this symptom of mastalgia. So what did her investigation show? All investigations were within normal limits, and ultrasound was essentially a normal study, and sonogram mammography also was normal. So this was a classical case of cyclical mastalgia, and 70% of women in their lifetime will have a cyclical mastalgia, and in Asian countries it is more common, and it has to be differentiated from what is known as premenstrual syndrome. I will come to that later. So now we come to the classification of mastalgia. How mastalgia can be classified? Mastalgia or breast pain. So it can be of three types. One is cyclical, the another one is non-cyclical, and the third one is chest wall pain. So cyclical means it's a pronounced pattern, pain experienced around luteal phase of menstrual cycle, associated with ovulatory cycles, more common in premenopausal women, often bilateral. It's a sharp shooting, stabbing, heavy pain, and it's easier to treat. Whereas non-cyclical mastalgia doesn't have any pattern, there is no association with menstrual events, pain tends to be well localized, often it is subareolar or medial, maybe bilateral. It's a burning, pulling, stabbing, pinching pain. And the third is chest wall pain. It is mostly due to costochondritis or teeth syndrome, which is it can be musculoskeletal or teeth or surgical trauma or referred pain. So these are the three types of pain. So the history is very important in patient when you are dealing with a case of mastalgia. So if it is during the luteal phase only, and once the menstruation stops, if the pain gets relieved, then it's very good. You have a patient of cyclical mastalgia, the chances of cure is around 60 to 70%. Whereas if you have a patient with non-cyclical mastalgia, then you should understand that whatever you do, the cure rates are very less. And the non-cyclical mastalgia, you get response in about 40 to 60% of patients. whereas chest wall pain is entirely a different entity. So this distinction should be borne in mind before we treat any patient. And what is the etiology of this breast pain? It is not very well understood. Many studies where they have done the assays of estrogen, progesterone and prolactin, they couldn't give any clue. But some studies have shown there is hyper-responsiveness of prolactin. Some say there is abnormalities of lipid metabolism. Some propose that in the luteal phase there is, because of the high estrogen to progesterone ratio, there is increased sensitivity of the breast epithelium, and fluid retention is also there, which results in increase in width of the duct, and because of that there is pain. But still the mechanism is not very clearly understood. And whether is there any association of mastalgia or breast pain with CA breast, like rarely it is a symptom of carcinoma of the breast, and advanced malignancies with the nerve involvement and things like that can have pain, but otherwise it does not predispose to mastalgia. If a young patient has got mastalgia, that doesn't mean that future chances of malignancy is very high. And many studies have shown that it's a psychological. Increased stress can precipitate this mastalgia. There is increased incidence of anxiety and depression in patients with mastalgia. So we always should have reassurance and explanation so that patients understand that it's a common condition. Most of them can be cured with conservative management, and it should be included in the first line of management, reassurance and explanation. And what are the other ways of treating this mastalgia? You always tell the patient to have a well-fitting brassiere, and two prospective studies have shown that with the use of well-fitting brassiere, the improvement, good relief of symptoms are there. And then you have primose or evening primrose oil, which is nothing but gamma linoleic acid. What does this do is it restores the abnormal fatty acid profiles, and it also decreases the sensitivity of the breast epithelium. So that is how it decreases the pain. 3 randomized control trials have shown there is no efficacy, whereas 2 randomized control trials have shown efficacy, and we in our institute use it as a first line of therapy. And vitamin E or Evion, this is also used. It also is shown to reduce the sensitivity of the epithelium. And 3 randomized control trials have been done. They show that it's not better than placebo, but still many guidelines. This is what is US guideline, but Indian guidelines say it can be used, and it can be used in doses of 400 milligram HS in the night, and people have found improvement with this. And another thing we always tell the patient with mastalgia is like to reduce the coffee and tea uptake. Caffeine and theophylline or theobromine, they can increase the sensitivity of epithelium. So if you stop completely these 2 things, there can be 85% reduction in pain. And complete stoppage of ethyl xanthines 8 weeks or more as supposed to have good effect on mastalgia. But if the patient in between resumes coffee or tea, then the pain will not get reduced. And if at all some patient has severe pain and is on hormonal replacement therapy, then we have to discontinue the hormonal replacement therapy for whichever indication it is started, and once the pain subsides, then you can restart. Even oral contraceptives can cause mastalgia, but this pain disappears after few cycles, and we can as well use alternative birth control measures. And increased dietary fat, flax seeds, herbs like ginseng and shasti berry can reduce the pain, but dietary fat, if you reduce, the pain is supposed to be reduced. And some studies have shown that using tamoxifen in the dosage of 10 milligram can cause much improvement in cyclical mastalgia, whereas in non-cyclical mastalgia the improvement is less. And it's a second line of treatment. So first line is like dietary restriction. You tell the patient, you reassure the patient, counsel the patient, explain the disease, then you can start evening primrose oil or vitamin E. And you have to say to avoid coffee, tea, chocolate for 6 months. With this, if the pain subsides, then you can give this Primosa and Evion only during the luteal phase of menstrual cycle. Majority of the patients will benefit with this. If even with this the pain doesn't subside, then we can start tamoxifen or second line drugs. So actually now we have finished what is mastalgia, and cyclical mastalgia and non-cyclical mastalgia I have told. The third one is chest wall pain. So this is how the algorithm goes. Like patient comes with the mastalgia and you take a good history, you examine both the breast, no nodularity or a lump. Then if it is dense breast, big breast, then you can ask for a ultrasound or a mammography depending on the age of the patient, and thyroid function test if patient is supposedly hypothyroid, and then you treat the patient as I have already told you. If it is non-cyclical mastalgia, the treatment success rates might not be so good. But if it is a cyclical mastalgia, it is very, very common, and the success rates are much, much better. The other disorders which include like unusual breast lesions, which are like uncommon, but this can have a therapeutic and diagnostic challenge. These can be systemic disease, benign tumors, or from metastatic disease. So cyclical mastalgia is a common condition, but now I will show you one or two cases of unusual benign breast diseases which can mimic some other systemic disease. So first is a cyst inside the breast. Like she was a 18-year-old lady with left-sided breast swelling and axillary swelling, bilateral non-cyclical mastalgia 1 year, history of nipple discharge, trauma or weight loss, and no significant past history. She was unmarried with no children and normal menstrual cycles, and no similar history in the family. And here you can see the cyst, big cyst occupying the axilla, as well as it was extending up to the breast. Clear fluid was aspirated. It was a 18 into 15 centimeter swelling lateral to the left nipple areolar complex extending into the axilla. An MRI was suggestive of lymphangioma of the left breast, and ultrasound also was lymphangioma. Here you can see the bright fluid uptake in the left breast extending into the axilla. This is the lymphangioma of the breast. So with the lymphangioma you have to excise. This is what we did. Here you can see the cyst with the septae. This is a big one, and once it was excised, this was the picture, and histological examination showed lymphatic sac with the lymphoid follicles around and with the fat lobules. So the cavernous lymphangioma is a rare entity and very few cases are reported, but if you like, why we have to operate is like it will have a pressure effect, and that can compress upon the ducts and cause some pressure effects, and this patient had some vague discomfort as well. And most of the times, because of the predominant lymphatic distribution, it is located in the upper outer quadrant of the breast, as I already told, because of the lymphatic drainage, and it is like composed of dilated lymphatic channels lined by endothelium. So this is the cavernous lymphangioma of the breast. So another tumor which is rare but can be common, most of the times mystucus malignancy, is a hamartoma. And why it is known as breast inside breast appearance on mammogram. That's why I have written breast inside breast. So this is a lady who was 32 years old with the left-sided breast lump for 8 months, which was slow growing, with no history of mastalgia, nipple discharge or trauma, no significant past history, married 2 children. She breastfed also with no history of oral contraceptive intake. And this is the clinical picture, and you can see the tumor there, and 7 to 7 centimeter swelling just below the lateral and left nipple areolar complex. And this is what I said, breast inside breast appearance on mammography, classical of hamartoma or teratoma. And here the ultrasonography showing the same tumor. Again one another picture of ultrasonography. So with that breast in breast appearance is hamartoma. Diagnosis can be made on imaging itself, mammography itself. So with that diagnosis, we made a diagnosis of hamartoma. We did excise this tumor under general anesthesia. Here you can see the tumor, firm, well encapsulated tumor coming out, just popping out. And this was the tumor, and this was the cut section. Here you can see the hamartoma elements in histopathological examination. See the ducts, all 3 elements. So this is very rare tumor again. It is known as breast in breast or slice of salami appearance, and it can be of 3 types, this hamartoma of the breast. It can be fibrous, it can be fatty or fibrofatty type, and it can have sometimes coincidental malignancy. That is why we have to remove this hamartoma of the breast. Second is ghost inside breast, nothing but he was a 24-year-old male patient from Nepal, and he had left breast swelling 3 years and no significant past history of pork and beef intake present. This was the guy, and here you can see the tumor, 2 into 2 centimeter medial to the left nipple areolar complex, and ultrasound also showed he had normal blood counts with eosinophilia. It was hydrated cyst of the left breast, which we excised, and here you can see the parasitic cyst with foci of calcification. So even parasitic cyst, it's an uncommon thing, but this is an uncommon location as well. That is what makes it rare. Common thing in an uncommon location makes it rare. It's usually found in other organs but not in breast. This was found in breast. We did excise it, and its primary site is very rare, complete excision. FNAC not advocated, and albendazole decreases recurrence. And recurrence, if you spill the fluid, is in the tune of 10%. So I think I have some more time. So coming to going on to other things like cyclical mastalgia, we discussed. So we have discussed 3 benign breast disease cases which were rare, and we discussed 1 common complaint, which is cyclical mastalgia. So what is the second line, first line? Like already I told you, first line is evening primrose oil, Evion. These 2 are the first line, with dietary restrictions to avoid coffee, tea, chocolate, plus reassurance. These are the first line treatment. So already we have seen evening primrose oil. The thing to note is evening primrose oil should be given in the dose of 3 grams or 300 milligrams. If you do not give the adequate dosage, it will not have effect. So at least 1500 mg BD or 3000 mg OD. What are the side effects? It can cause soft stool and headache. So second line drug we already discussed. It can be tamoxifen or bromocriptine. Tamoxifen is usually in the dosage of 10 milligram OD. You can see here the side effects include hot flashes, menstrual irregularity, nausea, bloating, vaginal dryness, rarely DVT and pulmonary embolism. And bromocriptine is 2.5 mg BID after gradual increase. Bromocriptine can cause nausea, dizziness, headache, postural hypotension, rarely seizure, stroke or hypertension. And the third line is danazol. Danazol, it's given in the dose of 100 milligram BAD. It is a testosterone derivative, so it can cause amenorrhea, menstrual irregularity, weight gain, hirsutism, deepening of voice, and hot flashes. So you have to be very clear on what you prescribe, when you prescribe, and it should be in a ladder. First you try the first line agents with appropriate advice, and if doesn't succeed, go to the second line, and with the second line also there is no improvement, then you should go to third line. It is not that first it is third line is started and then we change it to second line or first line. So this has to be very, very clear, and because mastalgia is one condition which is almost always misunderstood and mistreated, and it can cause lot of financial loss, as well as patient will not be happy and they will go for doctor shopping. So this is what one another study showed. This was like 93 patients were there. It was a randomized control trial. Success was defined as 50% reduction in mean pain score. So one group was given danazol, other group was given tamoxifen, the third group was given placebo. So you can see tamoxifen has got a very, very good improvement, 72%, whereas danazol 65%, and even placebo has got 38%. So like if at all, first is like evening primrose oil and Evion, not settle with that, go for tamoxifen, and then last resort is danazol. So this is what I said. This is known as the Mastalgia algorithm. First, patient comes to you with breast pain. You take a detailed history and then physical pattern of pain. You give a chart, pain chart. Mastalgia chart is available in the net as well. So you can give that pain chart, and patient will mark when was the menstrual cycle and how many days before and after she had pain. If it is mild and if it is cyclical mastalgia, first try to educate the patient and reassure the patient. If it is moderate or severe, and if it is lumpiness is there or lump is there, then we have to go for ultrasound bar mammography. If there is no significant finding, then reassure. If there are significant findings, then we have to do treatment for that. And education, I already said, like you have to counsel the patient that there is why this mastalgia is there, what are the treatment options, and tell the patient about firm support, brassiere, and then again we can give even analgesics and NSAIDs. And with most of the times with good reassurance and support, people will have less pain and patients will do well. And what are the treatment options? Like if patient is on hormonal replacement therapy, first we can stop it, or then we change the route, and then we see the pain, how much improvement is there. And if at all patient is not on hormonal replacement, then again I said we have to distinguish between cyclical and non-cyclical mastalgia. If it is cyclical, then already evening primrose oil 3 to 6 months plus an analgesic pain chart, most of the times effective. Then you start evening primrose oil only during the luteal phase. If it is non-cyclical, then we have to be very clear whether it is non-cyclical or chest wall pain. If it is chest wall pain, there is appropriate treatment for costochondritis or for referred pain, like that. If it is clear-cut non-cyclical and the patient is in childbearing age, then we have to see whether patient desires to be pregnant or not. If not, then the treatment will vary. If the patient wants to become pregnant, we have to be very careful, and first lines are good enough. And if at all patient is on hormonal contraceptive, then we have to change to non-hormonal contraceptives. And if there is no issue of pregnancy, then you can start tamoxifen, then later if that is not effective, danazol. The most important thing which I want to emphasize again and again, there is no substitute for reassurance and counseling. If you cannot counsel, then whatever treatment you give will not yield results. So first thing is to counsel, tell the patient it's a benign disease, she will do well, and we have to teach the patient breast self-examination, say that mastalgia is not a big problem, and she will become all right. And with NSAIDs, evening primrose oil and vitamin E, 90% of the patients will become all right. And only 10% which will have, whom the pain doesn't subside, will need second line and third line management. So even though it's a patient will come to a surgeon, doesn't always mean that we have to do surgery. This can be corrected even with medical management. This is what I wanted to say, and we will finish the presentation here. But what is the most important thing is, like, first classify the mastalgia when the patient comes to your outpatient department, whether it is cyclical, non-cyclical, or chest wall pain. If it is cyclical, you will have very, very good results. You have to just reassure the patient. First line, that is evening primrose oil and Evion. Most of the times you will have a very, very good outcome. If it is non-cyclical mastalgia, then it's a little tricky situation, because it is, the response rates are not very great. But still we have to do the same algorithm and treat. We have to see whether coexisting hypothyroidism is there or other factors are there. If they are there, that has to be treated. And chest wall pain, usually in young girls, thin-built individuals, costochondral pain or teeth syndrome is there, where we can easily make out, differentiate, and the treatment is different. So this is what is very important. Mastalgia doesn't predispose the patient to carcinoma of the breast. It's a very, very benign disease with good clinical outcome if treated properly. Thank you very much.